Well, good afternoon, everyone, and welcome to today's webinar, an education session where we're focusing on federal health IT regulations, what's new and how to, keeping up with the regs, as we like to say. We are so thrilled that you all have joined us today. As many of you know, that Hybrid Solution is Georgia's Health IT Center, and we've been assisting clinicians in the state for many years, over 10 years, with different federal and state regulations, including what used to be meaningful use, promoting interoperability, MIPS, and now we want to talk about some other things that really are applying and changing in 2022. We want to make sure that you have successful interoperability within your practices. So at this point, I would like to turn it over to our keynote speaker, who's been with us for such a long time and an integral part to the success of the work we do here. Many of you all work with Liz Hanson. She's been in the field for many years, but specifically with us, she's been working on promoting interoperability, meaningful use, MIPS, and anything that you need related to your transition from paper to electronic technology in your EHR systems, optimizing those and various activities. So at this point, Liz, we thank you for joining us, and I'd like to turn it over to you to talk about the regulations.
Thank you, Carmen. So we are talking about keeping up with the regs today. Specifically, what we wanted to do was some time now, it's a good time to do a level set and talk to our different members and the different providers and practices we work with about what the health information technology regulations are that are in place. And maybe you're part of MIPS, maybe you're doing standard MIPS with the quality payment program, or maybe you're in an ACO. So maybe you're on the Medicare side, maybe you're on the Medicaid side, and you were participating in the Promoting Interoperability Incentive Program on the Medicaid side until last year. But six months into the new year, those of you that were in the Medicaid program, you were doing a lot of really good things that we want to encourage you to continue to do. But some of these things that we discussed today may not be required of you, but they are absolutely recommended for you. So with that in mind, we welcome your questions and the folks that are on the MIPS side. So we're going to talk about some updates to ongoing federal information technology, health information technology requirements. We're going to have an overview of recent addition to these federal regulations, and then we'll talk about some tips on successful compliance with these requirements. So the first section is updates on ongoing federal HIT requirements. We're going to talk a little bit about health information exchange, a little bit about provider to patient exchange, a bit about safer guides, we're going to talk about electronic case reporting, and then, well, but a webinar B with me without talking about the security risk assessment. But it's only one slide, so it's not the real deal. So let's talk about health information exchange. Health information exchange has potentially 3 measures. It's really, you do either 2 of the measures or 1 of the measures in the promoting interoperability component of MIPS. So it's basically, it's a required component of MIPS. Now, most of you know in the promoting interoperability category, you can take exclusions, but this is a measure that regardless of whether you used to do it because it was required by Medicaid, but now you're not doing it anymore, or you're only doing it because you're going to be over 100, but you really don't want to do it, you don't want to use it. We need to change our way of thinking, because health information exchange is the way we need to transition patients from one provider to another, from one health treatment location to another. We need to be able to use health information exchange. So we just want to reinforce that this is what we consider a critical component of improving the quality of health for your patient. And so we really encourage everyone to listen on how we might do that. I do want to say the federal government and the state government expect practices to participate. As a matter of fact, Most of the times when I'm on calls with folks from the state government, HIT, or the federal government, HIT, it's almost as if they really think everybody's already using it. And that is far, far, far from the truth. At a minimum, you should be exchanging patient records or continuity of care documents or CCDAs via direct, which is an email type, a secure email type exchange, very secure and vetted. At the state level, that's provided, can be provided at no charge, a direct address for you to use. There's some grant money available for you to get involved in health information exchange. We just need to encourage you to whatever it takes you need to do it. There's some free services to make this happen, and you need to make it happen. Again, the federal government expects you to be doing this. If you use direct for your health information exchange, then that at least exchanges electronic information between provider and provider. And as I said just a minute ago, you can have a free direct address that is provided through our state HIE, supported by the Medicaid system within Georgia, DCH. However, that is not, if you don't go through your EHR to set up your direct address, then it's not necessarily integrated into your system. And there are some additional steps to the workflow. If that's what's keeping you from using electronic health information exchange, then please let us know. We'd like to try to help you figure it out. If it's a workflow issue, if it's a technology issue, if it's a you just don't want to do it issue, we'd like to help you get through that. You could participate in health information exchange, which is the ultimate way we'd like you to do that. And within MIPS, your requirements say that you can send and receive electronically using direct, or it says that if you're in a bi-directional health information exchange environment, you're like golden, good to go. All your patients would be then included, and that would be a wonderful score for everybody. So we'd like to do that. We'd like to encourage it. You can participate in an HIE such as our hybrid HIE. And again, there are some grant monies available. If we can help you establish that connection, we'd like to do it. Perhaps it's available through your affiliated hospital. And we're not talking about logging into the portal of the hospital and being able to check on your patients, although that's better than nothing. That's not what we're talking about. But if you're not on the same EHR vendor as the hospital, perhaps they do have a health information exchange that you can participate in. And we do have several hospitals in Georgia that have that available. So there are options for you to get involved in the health information exchange. It is a different way to do it, but if you're doing it in the best manner with the right workflow using best practices, it's beautiful. It's beautiful to behold. Now, you do need to work with your top 10 referring practices. You could just start with 5. Heck, you could start with 3, but at least start sending those direct messages and start the communication. Make sure your workflow is correct, because we have seen people not get good scores, and the workflow, the reconciliation was not occurring properly. 3 buttons got checked and 1 didn't. So it's up to the individual EHR system exactly what the workflow is, what boxes have to be checked for you to do the reconciliations. So how do you do that, and who is doing that, and are they doing it properly? Make sure you understand what the EHR requires, that everybody understands how to do that, and that they're doing it. Those are 3 different things, 3 different things. And any of those can be a challenge, but once you get over them, it's a breeze. We do also recommend you establish a community of care. This would be a situation where you would work with perhaps some representative from the hospital, providers at the hospital. You might also include some behavioral health folks in your area, maybe some public health folks, certainly some specialists in primary care and again, behavioral health. So that you're forming a community of care for that patient, that you're all exchanging the information, you're all working together for the good of that patient. And we believe that makes a difference to the quality of health. So off of that high horse, on to the next one, provider to patient exchange. Now this is patient portal. Often I forget and just call it patient portal. And that sometimes is confusing, but it's the methodology for provider to patient exchange. It's also a methodology for patient to provider exchange, or it should be. This is considered a critical component of quality care and improved patient health. So if you're in the MIPS program, you got to be doing this for promoting interoperability. If you're not required to participate in MIPS, you should still be doing this. Eventually, and I think we're almost there, your patients are going to expect this. And if you're not doing this, then you're going to lose credibility, believe it or not, as a practice if you don't have this available. You got to have it. You got to have it and you got to use it. And one of the reasons you got to use is that it is critical to you fulfilling the 21st Century Cures Act requirements and to ensure that you are not information blocking. More on that to come, but critical to that. The patient portal makes that, once it's all set up, makes that not an issue, not something you have to worry about. And also it has a very heavy weight in the MIPS category. So there's so many good reasons to do this. Let me keep going. Remember, there is a 4-day time limit on this for you to get credit for your promoting interoperability. And it is very high weighted. And when you exclude other portions, this particular measure gets heavier. So we really suggest everybody out there should have over an 80% on this, but your goal should be 98. It's a goal. You need to understand the required workflow and ensure the staff is informed and following this. Similar to my concern or things that I'm seeing with folks that aren't getting credit like they should for health information exchange, and then often just giving up. We have seen workflow issues with patient portal. If somebody shows me a bad patient portal score, then my first question is, tell me how you get this information. When is it done? Show me how it's done. To ensure that the workflow on the intake piece is right. And I will have to tell you that a large percentage of the time, how it should be done and what's actually being done is not the same, okay? Sometimes the problem is that the provider's not signing off on the record and closing it within 4 days. I know on the Medicaid side, that time frame was much shorter and a much bigger challenge. Most folks don't have problems with 4-day time limit unless they just don't know that it's a time limit. So it may be that we have folks out there that are uninformed and don't know that there's a time limit on when you can get credit for turning the patient portal on and uploading the records for that visit, every visit. Okay. Now, there is something that I need to discuss with folks. If you're not in the MIPS program, then you may think you don't need to pay attention to this, but we can see some of these regulations merging together. And so we're very concerned about this particular piece I'm about to talk about becoming something that's required as part of the 21st Century Cures Act, not information, the non-conformance to information blocking. So we need to bring it up, and it's a little techie. So we're just gonna talk about what it means to you and if it's something that you can do. Because if you have a certified EHR, as you can see on the left of your screen, this is a requirement for a certified EHR. So you just wouldn't believe how many EHRs we have had tell us they can't do this. And it's just at that level 1, level 2, sometimes the level 3 support just don't know it. So it is a bit of a challenge. Some EHRs we've had no problem getting this information, helping you get it. Some it has been a battle. But by and large, we've been successful because the EHR folks don't want you to report them to the certification board as being negligent or fraudulent in their certification. So rules on the left. If they're certified, they should have, that means that they are capable of this. And then really the net of this is that you have to provide a patient portal to your patient, a way for you to communicate with your patients and provide them access to their health information. But what it also says is this enlarged piece that says you have to have the system available so that your patients can get on their phone, their mobile smartphone, their mobile device, and access that portal using a third-party application or API. Now, an API is called an application programming interface. It interfaces to applications. There's an API between your Facebook and your Instagram, perhaps. Or perhaps there's an API that runs between Google and Facebook that continuously feeds you whatever you're looking up over on Google, over on Facebook. The API is the interface between those two applications so that they can work together. And as most of you have experienced, they work pretty dadgum good, sometimes scary. But in the health world, what we want to do is, especially for patients that don't have ready access to a computer or a tablet or a laptop, but do have a cell phone, then we want them to be able to use that mobile device to not only sign on to Facebook and Instagram, we want them to be able to sign on to a health application that can then access their portal so that they can look at one application and aggregate their different provider information in one place. So on one side of that API is a health app, and on the other side is your portal. And your certified system is supposed to be able to connect through that API. So that's something you need to ask your EHR company, a vendor about, and you need to be very tenacious. And if they don't respond, then you need to send them the specifications highlighting the part that says they got to do it. Now, again, it's a requirement under promoting interoperability, that under the measure for promoting interoperability. In other words, if you aren't doing what I'm about to talk about, then technically, even if you had a 98 score on your patient portal, provider patient exchange, it shouldn't get counted because technically you weren't meeting the specifications. Now, folks, we haven't had an issue with this on the MIPS side, but we've gotten a lot of buys over the last two or 3 years so that it really hasn't come up. I can tell you that on the Medicaid side for promoting interoperability, this was an issue. This was a showstopper. This cost people money. And they asked about it on the audit. Okay, so you may be thinking it's not something that you really need to worry about, but it is something that you're supposed to be doing and you can be audited for if you're in MIPS. If you're not in MIPS, then you just ought to be doing it because then it keeps you safer on the 21st Century Cures Act. Now, you have to be able to provide the instructions on how to utilize the API to access your portal and a sample third-party application that's accessible through your API. There should be several. You don't have to give several, but you got to give at least one. We prefer 3. And you can send this information in your intro portal email that you send out when somebody first signs up. You can hand it out at the check-in or check-out desk. You can have someone on the clinical side hand it out because when they hand it out, it makes people use it more frequently, we believe. So there's multiple ways to distribute this. If you send it out with your portal information, it's fairly transparent to your staff, as long as you've got the email address and everything is set up right, but you got to do it. So you have to do it. And here's how to send it out. But what is it? It's a document. Okay, now you can capsulize this and send it in your email. And this is just a sample. And it says that you can now access your patient records using your smartphone. It gives you multiple options for health applications. And these are third-party applications. They're not part of your EHR. They're independent applications so that they can, through an API, come visit your EHR and the cardiologist EHR and the rheumatologist EHR and the orthopedic surgeon's EHR, et cetera, et cetera. And they can aggregate, download that data into their system. Okay, so that's what we want the patient to be able to do, so they can have some ownership of their health, and they can better understand what's going on, and they can better share it with their providers when they talk to them. Now, the instructions. You have to understand what the instructions are through your EHR vendor. By and large, they look like what you see right here, that they just choose the app, sign in, create an account. They look for their provider on the app, and the message goes to the provider to validate the request, and everything is good to go. I have seen some EHR applications that require you to do to take a picture of a code to access it, and that one's is probably easier if you know how to do that. If you don't know how to do that, it's a little frustrating. So, but the net of it is you need to do it however your EHR is recommending. And then down here, we just have a little bit of graphic that just shows you that your client sends a request, the API runs out and gets it, posts it, puts it, deletes it, takes it to your EHR, and then brings them back what information they needed to get off of your system. I felt obligated to give us that graphic. I might have put it in the wrong place, but I don't think it'll help you understand any better. But it just goes between the two applications. And you need something like this document, although it could be much smaller and just added to the email, welcoming them to the EHR portal, to your practice portal, and that would be fine. Okay, now let's talk about the safer guides. Well, what fun. Now, the reason, first of all, I have to say you may not have heard of the safer guides, and I can appreciate that. I will not claim to be super familiar with them up until the last couple of years, but they've been around for a while. So let me just talk about how this came about. Since 2018, cyber attacks on the U.S. healthcare system have more than doubled, increased by 41% in 1 year. Okay, that's bad. Cyber criminals have started focusing on the healthcare sector. Well, actually, they were already focused, but they've really cranked it up. But they're shifting away from major hospitals and more towards outpatient offices. So we're pretty concerned about the safety of patient information within your electronic environment. Cyber attacks cost the U.S. healthcare system over $20 billion a year, and has compromised the data of over 45 million people. That's not good. They've grown more sophisticated so that it's harder to get the information back. They've increased the cost or the price that they charge. If they've got it for ransom and they're going to let you have it back, they've increased that price. And not only that, the people that fix it for you are charging more, and they don't recover 69% of the loss of the data that has been stolen. So this is a scary place, and we just need all to take a step back and think about this. The possibility of data loss and extended downtime due to lack of access and violation of information for our patients make the resiliency of the EHR system vitally important to healthcare providers. Now, I have to admit, until you put it in red and read it like that, it's not quite as scary, but it is a scary thing for many, many, many reasons. And if you're having HIPAA security risk assessment deja vu feelings, you should. So, because of all this risk and the recommendations from the experts that say that this needs to be a new national policy to stimulate the implementation of best practices, here we are with the safer guide requirement. SAFER is an acronym, very cute acronym. Safety Assurance Factors for EHR Resilience. Aren't you glad I explained how resilience played a part in all of this? It's hard to slip that word in, but they were developed and released by the ONC in 2014. In 2014. And the purpose was to help health systems conduct proactive risk assessments of their electronic health record environment, their policies, their processes, their procedures, and their configuration. They were updated in 2016. And the SAFER documents are actually user guides with lovely material that walk you through exactly how to minimize your risk in these areas. Very slick, very nice, very well done. Nobody used it. Updated in 2016. Study in 2018 says, guess what? People aren't using this. Now, I think you probably aren't surprised because you probably weren't using it. But now, apparently, it's gotten some attention. The situation, the environment has gotten way too sketchy. So now we're going to see us being required to do this instead of it being voluntary. And this is a requirement of the quality payment program. So it comes under the promoting interoperability portion, similar to the way that information blocking does. That's where you check off your information blocking statements. And those are going to look a little different this year, but I didn't put it in the session, sorry. But to meet your requirements for this year for promoting interoperability, the requirement is that you complete the high priority practices guide. That is a guide called high priority practices. It's weird because it sounds like you're talking about priority. Well, anyway, I'm sure you understand. But these are the practices that are of highest priority within your medical practice. So that's my problem with two practice usages. You have to attest to completing the high priority practice SAFER guide. Okay, just the high priority one, not all 9. Hospitals have to do all 9, not all 9, just the first one. And this first one is really cool because it's you just get your toes wet. It gives you a good introduction to the guide. It's more of an overview and you'll be more familiar with the answers potentially. But here's the little twist. For your attestation requirement, you can answer yes or no to completing the guide and still pass. Again, you can answer yes or no for 2022 only and still pass. CMS wisely felt like folks needed a chance to learn how to utilize this guide. And so they're only making you do the first year, and they're not even really making you do it, because you can say, no, I didn't do it, and that'll be okay. What is not okay is not answering the question. If you leave it blank, you will fail the promoting the interoperability component, fail it. So you cannot do it and pass, but if you leave the question blank, you will fail the entire component, lose those 25 points. Don't do that. Don't do that. Maybe you're someone that we're helping and we'll help make sure that doesn't happen, but for goodness sakes, don't do that. You can actually report this at the group level, which would make it less risky for you to make mistakes if you have a lot of providers and you, especially if you report at the group level. So that's convenient. So don't make this mistake. Of course, what we really want you to do is to do that first guide. It evaluates your safety practices. It identifies and prioritizes risk, and it helps you with your mitigation plan. So it's a really good document. And of course, the penalty for not attesting is a 0 in promoting interoperability. The penalty for not doing it, that's not existent, but we expect it to be in the future. Expect. I did want to point out on the bottom right side, you do actually have a picture of what the guide looks like. It's a user guide. It's got a table of contents. It gives examples. It tells you, it has a worksheet for you to gauge whether you're doing something. It has a place for you to put assessment notes. It has examples of what it is that you should be doing. It has people that you should include on it. It has links to categories or a few other guides that are more specific into a particular category. For instance, contingency and planning guide. This first guide just asks a little bit about that. There's a whole guide on that. Okay, so if you want to go deeper in it and just get as deep as you can, then you got a guide for it. And it just gives you all the tools you need to be successful. Do you do it by yourself? No, you don't do it by yourself. You need to bring in some of your subject matter experts within the practice. Sorry, thought I had another slide on that one. So you're going to need to include, especially if you have a compliance officer, or if you have, if you don't have a compliance officer, I think I say later, you need to get one, or make someone a compliance officer so they know the rules and can stay up on this. So especially if you have someone in charge of HIPAA and your security risk assessment, your IT folks, that may be an independent organization that you hire. And so you just may need to send them emails with questions and watch how much that might charge you. If you have an internal one, then they should be able to come together with you for a meeting. You want to make sure you include someone on the clinical side, have your providers, have some mid-levels, have one of, definitely have the administration in there, so you can talk about some of these issues so that everybody's working together on this. Everybody doesn't need to be involved in everything, but you do need to have your subject matter experts participate. All right, electronic case reporting. Now, this seems like it ought to be in the news section because as it turns out on the MIPS side, everybody now has to do this for 2022. However, we felt it needed to go here because it's actually been around for quite some time. And it's been an option for people to choose for quite some time. I don't know, I'm pretty sure I could name on one hand the organizations that are actually doing this today. And most of them would be health systems, not practices. So we just have to say that if there's one lesson that was learned from COVID-19 and the pandemic is how important it was for health agencies to have timely and complete patient information from the get-go and ongoing. So for tracking, for case management, for contact tracing, for so many good reasons. And of course, we didn't really have this in place at the beginning of COVID-19. I suspect that many of you now are entering in, if you're doing testing, you're entering that data. You're probably going to the portal, signing into a portal and logging in this information. I ask people, it's one of my go-to questions these days, when do you do that? Do you do it after you get every positive, or are you doing it once a day, or are you doing it once a week? And some of the responses are disappointing. They're certainly not timely. And this is a situation where 2 days can make a difference in how your organization gets additional support, how your entire healthcare environment is supported at the government level. So we just have, many folks had some concerns about stepping up the electronic case reporting so information could be received in a more timely manner. So electronic case reporting provides data during routine periods as well as during public health emergencies. So this is a resource or a tool that you can use ongoing all the time. Most of them will report 100 plus type of cases, things that are required to be reported. The data includes information on patient demographics, comorbidities, immunizations, medications, and of course, some kind of treatment or some kind of diagnosis that may have occurred or a positive to a test. It is a new required measure for MIPS promoting interoperability. in the past, you were to do the Georgia immunization registry, if that applied, but you could pick your other registries. And one of them could have been ECR, or you could have actually exempted several of those or all of those, and many of you did. Now the ECR, or electronic case reporting, is required, and your certified EHRs are required to do it. So we've got another situation like we did with API. Your EHR vendor may not know what you're talking about when you ask about this, and we'll be glad to give you some supporting information or some moral support on a call if that might be something that you needed. But electronic case reporting, when it's done through your EHR, is transparent to the user. For example, you might get a positive result on a COVID test. That data goes into your EHR. If you are set up to do electronic case reporting, as soon as that data, that report goes into the EHR, those results trigger the message to be sent, and it includes the data to fill the form out that you're probably having to fill out manually right now. And that information electronically gets sent in the background, transparent, no one seeing it occurring. You can certainly get reports that tell you that it's occurring, but it does occur in the background, and it doesn't require a person to enter the data and make mistakes and take up their time and get frustrated, and it doesn't require any filling out manually of a form. It's a beautiful thing, but not many folks are doing it. So we really want to encourage you to do it, and there are some resources to help you do that. Now, for 2022, although I've told you it's a requirement, there is an exception available because CMS understands that because this requirement was put into place late last year, that many EHR vendors do not have this ready. I've told you, very few have this ready to go. And that's okay. If your EHR is not ready in 2022, then you can take an exclusion for it. But of course, you know that we're going to recommend you get some document in an email stating that they are not ready. And boy, that has not been easy. Now, we can ask the vendors and then back off and come back at them, but if they, and not really worry about it now, but we expect them to produce some statement by the end of the year, because we need to know at least by the last 90 days if we've got it or not have it. And of course, we need it by next year. So we don't want you just asking your vendors about it. We need you to ask your vendors when, if they have it yet, and if not, when they plan to have it. As I said just a few minutes ago, that this functionality is one of the functionalities that really reduces burden for healthcare providers or staff. It doesn't disrupt the workflow. It eliminates manual data entry. It's providing a legal reporting providing for a legal reporting requirement, real-time reports. It's just a wonderful thing. Not only that, it can be facilitated that a message, if something has to occur, you have to, perhaps some of you know that sometimes when you report something for your case reporting, the CDC might come back and tell you you have to do some action. And so it'll, most solutions will actually allow you to come back and do that and have that as a pop-up message. So, but we really need you to be on electronic case reporting for your reporting and receiving of updates. And I don't think your EHR can do it, but I need you to find out. I'd love for you to tell me if they can. We're kind of keeping a little list of which EHRs have said we can't do it yet. We're going to do it, but we can't do it yet. Which ones can do it and which ones aren't responding. So if you want to just put it in chat or email us if you're EHR, if you know, or if you find out later after this webinar, we'd love to hear about it. Now, I told you I had to say something about the security risk assessment, and I do, because I don't care if you're Medicare, I don't care if you're Medicaid. Medicaid, I apologize, the last couple slides really were requirements on the Medicare side for MIPS. We do reinforce that you should be doing these things as well. Everybody's concerned about HIT security and the security risk assessment. And one of the things I have to say is, if you can hire somebody to do this for you, if you can hire somebody credible that doesn't cost a fortune to do this for you, then do it. Or if you can take a training where you get fully trained on how to be a security officer, then do it. All practices have to do a security risk assessment every year. You have to complete the assessment, date and document the assessment, determine your risk, develop a mitigation plan with target dates. Everybody needs to do this. Everybody needs to do this. At any given time, you can be audited for this. And if you don't have the security risk assessment done, and if you don't have your policy and procedures in place that back it up, and if they find you aren't doing them, and or they find you aren't doing this, you'll get fined. It's not a good place to be. And worse, the worst thing about it is that you're risking your patient's information, and that puts your patients and their health at risk. So that's not okay. So make sure you've got all these policies, you're updating your manual, get that security risk assessment done, get it done by the end of the summer. Don't leave it until the last minute. You might be able to mitigate all your issues by then. It makes a lovely complement to the SAFER guide. It really does. Sorry, you'll see a lot of familiarities between the two. So enjoy. All right, now we're going to talk briefly about the 21st Century Cures Act. We're going to circle back and mention ECR again because it is new for some folks. And we're just going to briefly mention the new MIPS format that's going to be available in coming years. So most important, I think, is the 21st Century Cures Act. If you don't know what this is, go look it up and study it. Excuse me. It was passed in December of 2016. It didn't take effect when it was supposed to take effect, thank goodness. It was in the final rules in March of 2021, but we got until April of 2020, but we got until April of 2021 for it to go into effect. And you may remember, if you were participating, we did, I'm pretty sure in that March or April, we did a webinar on them, and we just felt like the exposure wasn't super good. That most providers had heard of this, but had no idea how it impacted them or if it impacted them. And if you're a provider, it impacts you. It includes provisions to promote health information interoperability and to prohibit information blocking. So again, it ties in with that HIE component as well as the patient portal component. They are all about information blocking. Information blocking is any reasonable or necessary activity that is likely to interfere with access, exchange, or use of electronic health information. And folks, I have providers tell me, oh, I make those decisions. I decide when someone gets to find out about something. That's the way we do it, or that's what our policy is. That's bad. And that will get you in trouble. You don't get to decide when a patient gets to see their information. The 21st Century Cures Act has made that decision for you. It is designed to give patients and their healthcare providers secure access to their patient information. The goal is to increase innovation and competition by fostering an environment or ecosystem of new applications that provide patients with their choice of how they can view their health care, access their providers, or what providers they even see. It calls on the healthcare industry to adopt standardized application programming interfaces, APIs, which we already discussed. It helps allow individuals to securely and easily access their structured health information. It includes a provision, this is in red, requiring that patients can electronically access all of their electronic health information, structured or unstructured, at no cost. And the intent is for them to do this through a patient portal and for them to be able to see their information as soon as it is recorded. To further support access and exchange of electronic health information, the rule implements the information blocking provisions of the Cures Act. Clinicians and patients can experience information blocking in many forms. If a patient doesn't have access to their records, that's information blocking. If you have it available in an electronic environment, we're not even talking about non-electronic here, sorry folks. We're just talking about if you have an EHR. If you have an EHR, you should have an electronic environment. You're expected to follow these rules. You have to give the patients access to their records. They have to be able to share those records with other health providers. You might be a healthcare provider asking on behalf of a patient for some patient records, or because there is some information that you need to know, and you can submit a claim of information blocking. If your EHR is not performing properly so that patients can't get to the patient portal to get the information, you can accuse them of information blocking. Oh my goodness. It just comes in so many forms. If you refuse to link to clinical data registries, and you should or you could, that could be blocking. If you refuse to transfer or mitigate data, if your vendor won't do a transfer for you, if you move to a different EHR and so you can't get at your old EHR data, that's information blocking. And connecting EHR systems to local health information exchanges will help you with some of the things that we've talked about today. But if the patient can't get the information, it would still be information blocking. So it still needs to be made available on the portal. Now, this rules out 8 exceptions to the definition of information blocking. I'm not going to get into all those exceptions for you today. They're not simple. You may think that if you decided that a patient seeing a test result was harmful to them because of the emotional distress, so you didn't do it, information blocking, because emotional distress doesn't count. So it's important that you read this in most situations. These exceptions are not simple, and you have to be very regimented and very documented about why you took these exceptions. And we would certainly recommend you get an attorney that is familiar with them involved before you set your policies. Because if you have a policy that goes against the Cures Act and thus is information blocking, you're subject to a fine. And let me give you an example. I've got a practice that if they get lab results in on a Friday, on a late Friday, they do not have them posted until someone gets to look at them sometime late Monday. And that's their policy. And because they thought if it's their policy, it would be acceptable, they believed that they were following the requirements. They were not. That policy states that they're information blocking. You don't get to decide that the patient has to wait until you get to look at it. That's not the deal. So personally, I love it. I love going in and seeing my test results within, a couple hours, and then getting something through the portal from my provider probably a day later or 2 days later. I like going and seeing it. Most of your patients don't know they can do this. So they're not really turning people in for information blocking. They're not really raising Cain about it or having any issues. But if someone works in healthcare and you make them upset, they'll probably turn you in. This will be similar to HIPAA, I believe, in the way that we see claims registered, unless it's a real blatant issue. But the point is, you're supposed to have the policies to make sure that you're not infringing on this policy, on this requirement. So what do you need to do? You need to review the resources provided by the ONC and professional societies. There's a ton out there. Just go read it. Spend 30 minutes, read it, then maybe spend another 30 minutes and reread it. Determine if you've got a compliance program. If you already have a HIPAA compliance program or somebody that takes care of HIPAA and OSHA or any compliance programs, this may be a beautiful fit. Okay. They're used to making policies. They're familiar with these types of policies. Good fit. Consider including the subject matter experts in your practice. And this is similar to the ones that I recommended when you do your SAFER guides. Go figure. Compliance officer, legal counsel with health expertise. Folks, not just legal counsel. You need legal counsel that has health care expertise and who's knowledgeable about the information blocking rule and regulations. Somebody with IT expertise, real IT expertise, regardless of what they may say. You need somebody that actually does have it, and information privacy expertise within your organization. If you don't have these, you may need to pay somebody to get it, but you need to get yourself set up to be successful and not have a problem here. Okay, you need to review all your policies related to responses to information requests. You need to update those policies and procedures as needed. So it doesn't say that you wait until Monday afternoon when you've checked those lab results for those to be available. Your policy really needs to say those lab results will be available as soon as they are received, unless there's a hardship reason not to put them or an exception. Again, not going to go into that, but your policy needs to be that specific. Make sure that you're including HIPAA policies and all your confidential and sensitive patient information in your thought process about this. Include in your policies information related to adolescent health. That is part of some of your exceptions. If you work with adolescents, you know that we've got some issues with the patient portal, and their parents being able to access the portal and et cetera. So, and privacy there. So you could have some exceptions there. You need to address each of the information blocking exceptions prior to using the exception. So you could have a policy that says when you might fall into one of those exceptions prior to you claiming that you did it. And then you need to define what reasonable is. Reasonableness is. That is just a little crazy for me, but I can assure you that this makes sense, because what your provider might think is reasonable, the federal government might not, probably does not. Okay. Now, the federal government says to be an information blocker, the physician has to know that the practice was that what you did, what the policy was unreasonable and likely to interfere with information exchange and the Cures Act. The problem with this is it makes it sound that it's okay that you don't know the problem, but they expect you to know. So by virtue of them making this rule, you're required to know this. So if you came back and said, hey, I didn't know that I had to provide this within 30 seconds of getting it, I'm being a little facetious, but not much. That's not an excuse. You'll still be fine. Kind of not a good situation over there. So don't fool with it. Don't fool around. Remember, patients and providers can report you. There are penalties. You need to look at the policies. There's all these scenarios. There's all these examples, all this great information. We've got links to a lot of good resources for you. I think if you just read, especially these first two, I think you'll be more comfortable with what it is that you have to do. But what I have found is most of you need some policies. I'm not seeing them out there. You may be doing the right thing, but I'm not seeing the written policies. All right, and where do you start? You need to ask yourself these questions. And we'll be sending, I believe we'll make this webinar available and you can see what these questions are, but you need to know where you are in your organization. How are you doing this? What are your time frames? What do your policies look like? Do you even have any policies? All these are excellent questions that you need to ask. And if you don't need know the answers, you need to find them out and mitigate it and create a policy. Now, as I said, I'd mentioned ECR again because it is new to so many people because it's now required and it was never an issue for them because they were doing 2 registries without it. And now they have to do this. What we do know is that it's garnered a lot of attention. It's not required for everyone, but we need you to be prepared because it is not outside of the realm of imagination that the government would want everyone that has an EHR to do this. It is a time saver. It's more efficient. It's effective. And you need to ask yourself, how are you reporting COVID data? There may be a very inexpensive way for you to do it without using up your manpower. Now, MIPS value pathways, told you I'm going to run out of time, is a new component of MIPS that doesn't even start. It's available to start in 2023. It's voluntary through 2027. The only reason we're bringing it up today is because a lot of people got spooked by it 3 years ago when it was announced, and it's coming on a lot slower than we anticipated. So stay tuned. We do a monthly webinar where we'll come back and revisit the MVPs when they get a little bit more viable for folks that we talk to. So don't worry about MIPS pathways. It's not that different, and we're hoping it'll help some of our specialists get better scores. More to come. So our tips: read your summaries of your laws and your rules and your requirement. Read the summaries. They're only a couple pages. Stay vigilant. Look at your newsletters. Let Highbridge help you. There are lots of resources available to you, but you need to keep up with the rules. You need to keep up, not catch up.
I love it. Thank you. Thank you, Liz. Great information. And I do agree that there's certainly some opportunity for us to break down the information that you shared today into smaller segments, and then we can present those back out to the group, because that was such a vast amount of information. So thank you. Thank you. You are definitely the subject matter expert. We also appreciate your commentary that goes along with it. So thank you, ma'am. I don't see this as an opportunity. I know we're at the top of the hour. Opportunity for any questions to go in that Q&A box and we can read them. If you think of others, certainly you can email us and we'll make sure to address those. Liz at the top of the presentation mentions an opportunity for HIE connection funding, or funding to help to offset those costs, offered through GHIN, the state designated HIE, through Highbridge. And so happy to provide that information to you as well. I put the email address in the chat, just reach out to us. But anything that you need, of course, we serve as your health IT center and happy to help. And Liz has, we have got the experts on the screen now. It'll be Liz herself, Phoebe Nouns, and Selena Williams. And if I can assist anyway on the HIE, I'm happy to do that as well. So I want to thank all of you for attending. It's been a great session, wonderful and helpful information. And again, we will work to get this information back out to you all, as well as provide additional education around these important regulations through 2022. So thank you. And with that, I wish everyone a wonderful idea, or a wonderful idea. I see ideas coming through. A wonderful day. And we're here to support you. Thank you for all the positive comments and feedback that's coming through. You all have a wonderful day, and we will see you next month. It's our webinars are the third Tuesday of every month at noon. And on the MIPS, if you're a MIPS participant, we have a virtual office hours the second Tuesday of every month at noon. So we look forward to seeing you. Thanks so much. Have a great day.